Thank you very much. Thank you. Thank you for having me. It's been quite a few years since I visited your beautiful island. And last time I was there, I've lectured with Dr. Gimeno. Obviously, he's not here with us today, but I would forever be grateful to him as my mentor. I was given the task of discussing the key to a successful MMA in the treatment of sleep apnea. I hope the title will be self-explanatory at the end of the talk. Now, every MMA is an individual plan for each patient, okay? The plan must be designed to maximize the airway expansion without compromising facial aesthetics or resulting in any long-term negative sequelae. MMA was first, for the treatment of sleep apnea, was first published in the 70s. So it's been around for a long time. I, along with many other authors, have published some of the essence, some of the keys in terms of performing MMA in patients. And they're very simple. You want to maximize the advancement to maximize airway enlargement. You want to be cognizant of the facial changes and not compromising them. You want to make sure that the occlusion is stable. And last but not least, you want to minimize complications. You do not want to have your patient to be worse off than before the operation. Couple of examples of how each surgical plan could be very different. This is a patient where there's significant maxillomandibular deficiency. And you could see it was, I think it was a 28 millimeter maxillomandibular advancement with counterclockwise rotation. Whereas this patient, primarily, it was a significant maxillary advancement with lengthening, and the mandible was just a bit rotated. Why? Because if I advance the mandible, the patient will look poorly. Okay, so all the surgical plan, everything was discussed in detail with the patient prior to surgery to discuss all the sort of the ramifications of the movements and etc. I've been doing MMA for a long time, and this is my my case series that will be published in a couple months, I believe, and it was over 1,000 patients. I usually like to use RDI as an outcome parameter because I think it's more relevant in improving symptoms. So you can see that MMA can be very successful in reduction of the severity of sleep apnea. Looking at about 1,000 patients, or almost 1,000 patients, the surgical success based on what's typically used as a surgical outcome assessment is about 73% in all comers. Some of you who know the literature will think, geez, that's not very good. I thought the success of MMA in sleep apnea is 90, 95, even 100%. Well, those are very small case series. Okay, if you compare my data as a single surgeon versus the most recent meta-analysis of about 500 patients, pulled from many studies that was published in 2016, you'll see that the overall surgical success was higher in my case series. Why is the meta-analysis a little less successful? I suspect it may very well be the heterogeneity of the pooled data. And what's interesting in my case series is that the first 500 patients did not do as well as the second 500 patients. Why? Well, that is because I've learned over the years. And looking at the outcomes assessment, younger patients with less severe sleep apnea, larger advancements, and patients who are, who are not overweight or not significantly overweight tend to do better. Why do we emphasize that the advancement needs to be large? That is because sleep apnea gradually worsens as we age. Whether you have surgery or no surgery, the clock does not stop ticking. Sleep apnea will gradually worsen and gradually, and how fast or how severe, nobody knows. Nobody can say, but there will be a gradual deterioration. So we want to improve the patients as much as possible when we do an operation. Why? Why do we why does sleep apnea gradually get worse? Because our body changes as we age. And if you look at some population-based studies and looking at the prevalence, there's a gradual increase as we age. Okay. Now, in my opinion, the most important prognostic factor is not the age, weight, or OSA severity. It is the surgeon performing the operation. Why? It is a surgeon that decides who he or she will operate on. It is the judgment of clinical judgment in terms of how the surgery should be designed and how the surgery should be performed in terms of surgical precision and execution. This paper was published very recently. Unfortunately, I'm just seeing increasing number of patients that are coming to see me for second opinion because they have problems and persistent sleep apnea after MMA. Okay. Why do these cases happen? Because it's error in planning and patient selection, error in judgment, and error in surgical execution. Let's take a look at some examples. This patient came to see me from Indiana. He had an MMA operation, no change in symptoms. Why? He was advanced, what? If you take a look at the bone gap, 3 millimeters, 4 millimeters, I'm being generous here, okay? That's why he's no better. And then the surgeon performed a genioglossus advancement. Unfortunately, genioglossus advancement is not a very good operation, and it's very unpredictable. The patient still was very symptomatic. I had to do a revision MMA. Anytime that you do a revision MMA, it's always more difficult, has the higher risk, and the advancement often is limited due to a lot of scarring. You just can't pull the bone or the maxillomandible forward enough due to scarring. He had a decent outcome. You could see that I had to deal with all these sort of hardware that they're completely embedded in bone, which can't be removed. Okay, so I think he had about a 15 millimeter advancement. The parents of this patient brought the patient to see me initially when she was about 12 or 13, and they wanted her to have MMA, and I told them no, because at that age the bone was too soft and spongy and very difficult operation and difficult advancement, because the advancement distance is going to be very limited. Well, she had an operation, she had an MMA done by another surgeon. Unfortunately, there you can see not much advancement. The maxilla you can clearly see is lengthened. This is a clockwise rotation. Okay. The patient still had problems and not much better. So they came back to see me and I did a revision MMA on them. There you can see that I had to deal with embedded hardware that I had to cut through. The patient had, I think, about a 11 or 12 millimeter advancement I was able to do. And the patient did improve quite a bit. There you can see before the first MMA, after the first MMA, and after the second MMA that I did. Okay. You want to make sure that you do a good operation by maximizing the advancement. But all I see whenever patients come to see me with persistent sleep apnea symptoms after MMA done elsewhere is insufficient advancement. This patient came to see me from Philadelphia. He had an MMA, had no change in symptoms. Why? There's about a 2 millimeter advancement. He was very symptomatic. I had to do a revision MMA. By the way, you could see that the patient had a big genioplasty. Genioplasty does nothing for sleep apnea. It is a cosmetic operation. Okay. I had to do a revision MMA. Anytime you look at X-ray or CT of a revision MMA, it's never pretty. Why? Because you have to deal with altered anatomy, a lot of hardware, the titaniums that you cannot remove. You have to, the surgeon that doing the revision surgery could only put the plates at places where there's good bone to place the plates. He had not a very good advancement, about an 8 millimeter advancement due to a significant amount of scarring. You know, he did not achieve much improvement after the revision MMA that I did. Okay, unfortunately. And this poor patient had to had a pharyngoplasty afterwards. Again, no improvement. He still struggled. Okay, so the take-home message: you want to do a good operation the first time around. Unfortunately, many patients, again, when they come to see me after MMA's done, the advancement is typically limited. You could see the ruler yourself. It's probably about a 5 millimeter advancement and at least a 5 millimeter genioplasty. Okay. Not a very good operation. Patient came to see me for a second opinion, still very symptomatic after MMA, which is not, you shouldn't have, it's very uncommon to have still similar symptoms before and after MMA, in my experience. Another patient, same, big genioplasty, 5 millimeter advancement, symptomatic after MMA in patients from California. And you can see, again, the genioplasty on this patient was about the same, if not greater, than the advancement. Okay, so you can see that now the patient has a big chin. What's worse is that the patient now has a crooked face. Okay. That is not symmetry. That is not facial symmetry on top of persistent sleep apnea after an MMA. Another patient, same thing, big genioplasty, which does nothing, very limited advancement, 5 millimeter at best. Okay, this is not what you want to do. Again, genioplasty does not include the genioglossus muscle. Okay, even with a good genioglossus advancement, it is pretty unpredictable in improving sleep apnea. And genioplasty, forget it. It does nothing for sleep apnea. Increasing number of patients after failed MMA are offered inspires hypoglossal nerve stimulation in some of these patients. This patient had hypoglossal nerve stimulation, as well as this patient. So they're not using them. Why? Because it's not helping them. If your MMA surgeon is offering you hypoglossal nerve stimulation, stop right there, get the CT scan, and get a second opinion to see whether you had a good advancement. Okay? If the advancement is insufficient, do not have the same surgeon perform the hypoglossal nerve stimulation. Sometimes it's not only the limited advancement. This patient had a limited advancement with a big genioplasty and a dramatic impaction of the maxilla, where she now has no teeth show as smile, along with some facial pain and eye symptoms because the screws are right near her eyeballs. As well as significant nasal obstruction because the severe impaction dramatically reduced the overall nasal volume. I had to do revision surgery, clean her up, lengthen the maxilla, try to restore some smile. Oh, by the way, after MMA, when she chews, food comes out of her mouth because her lower lip posture is incompetent. I had to do 2 mentalis muscle resuspension to try to restore the integrity of the lower lip function. Still not there, but improved. Middle-aged man from California came to see me after MMA. Unfortunately, developed bilateral non-union. Usually when you have mandibular displacement and non-union, you're going to have infection. Okay, there you can see bilateral non-union with malocclusion. Due to infection, the hardware had to be removed. After a period of time, he had bilateral mandibular reconstruction via external approach using hip graft. Why did he come to see me? Because he has chronic pain and he can't chew normally because he doesn't feel like his jaw is his. Okay. That's a lot of metal. Even with that, the jaw still feels unstable. This is a patient from Washington State, came to see me 3 months out after MMA. Significant malocclusion. Why? Because he has bilateral non-union pathologic fracture. Fracture right there, dead bone. Fracture right there, dead bone, non-union. Osteomyelitis. I had to do 5 operations to clean him up and try to save his jaw. Fortunately, I was able to do that. Okay. This patient had MMA, he's from California, had MMA, and after the first MMA, he had another 3 or 4 operations. And then he came to see me. Why? Because he still has sleep apnea. His jaw doesn't feel right. I take a look in his mouth, pus still coming out of the mandible. Okay, he needed another operation to clean him up. If you take a look at his history, he had the MMA. You can see malocclusion. He had this big hunk of metal placed on the chin. I don't know what that is for. Okay. There's a big piece of metal. I guess it's using titanium as a chin implant. This is a genioplasty. This is a geniotubercle. So genioplasty does nothing, okay? The patient had pathologic fracture on one side, pathologic fracture on the other side, malocclusion, bilateral non-union, require reconstruction, clean up, multiple cleanup surgery. I think he have at least 5 operations. And he still has sleep apnea. Why? Because the advancement was not good. Okay. The face is not very even after all said and done, and he still has sleep apnea. Still symptomatic. This lady came to see me. She was a very successful attorney. She's from New Mexico. Had MMA surgery. Not a very good advancement, but okay. But the problem? Bilateral non-union. Bad genioglossus advancement. Some teeth were injured. Infection, non-union. This lady had, I think, at least seven operations, multiple reconstructions after the initial MMA, mandibular fracture, And she still has sleep apnea. No change because of all the problem with the jaw receded back and basically no advancement was done. The patient had to retire and go on disability due to chronic pain and persistent severe sleep apnea. This is a patient from Baltimore. He actually came to see me in the first place before any surgery was done. And he didn't even try CPAP. He wanted to have MMA. I told him that he's not the most straightforward MMA because his deep wisdom teeth impaction was middle age, and he didn't try CPAP. I always tell patients to try CPAP as a first line of choice. It's not surgical. You should always try it. Okay. He didn't like what I told him, and he went and had an MMA surgery. Not a very good advancement, but that's not the worst part. Mandibular displacement, non-union, infection. You see these cases, similar story, okay? Bad advancement distance, problems after problems after problems. So had to have the plates removed, try to resolve the infection, went back later, try to restore the mandible. The surgeons told the patient that he's good now. Well, he still can't chew, still doesn't feel right, came back to see me for second opinion. I took a look in his mouth. I see exposed bone. You do not want to see bone when you look in someone's mouth. After MMA, after all said and done, the patient still has sleep apnea and he now has a mandibular continuity defect. Not good. This picture tells you a lot about this patient. Well, first, he has cotton stuffed in his nose on both sides. Why? Because he had nasal surgery and resulted in empty nose syndrome. Not good. He then had MMA. He came to see me because he still doesn't feel good. Okay. He still his sleep apnea is not much improved after MMA. Well, not just MMA. He first had the dome operation that resulted in significant amount of bone loss and compromised two front teeth, had to have root canal. There you could see, you don't have to, you could just look at it yourself. Look at the ruler and look at the bone gap. I give it at best 5 millimeters, not a good advancement. That's why the patient is still symptomatic. And then had hardware failure, removal, had to clean up. But last not least, he has non-union from the maxilla, from the maxillary osteotomy. This patient still has his braces on after I think about at least 5 years. Why? He's afraid to take the braces off because he thinks his two front teeth are going to fall out. And he still has sleep apnea. And he's struggling with CPAP. And he has chronic facial pain. And he cannot chew hard food. Okay. These cases are horrendous. Another patient that had MMA came to see me, still has sleep apnea, still symptomatic. I take a look in the mouth, granulation tissue coming from the mandibular osteotomy side. Not good. Why does the patient still have sleep apnea symptoms? Because the advancement was not very good, but the patient now has a big chin. Well, the patient first had dome, didn't do much for him. There you can see granulation tissue right there, okay? He had the MMA surgery. So this is when I saw him. I see the granulation tissue. I said, go back to your surgeon. Went back, see his surgeon. You could see that the mandibular segments are displacing. Look at the bite. Look at the bite. He had the plate or whatever was done to clean things up. Then he came back to see me because his bite is off. I opened him up, clean everything up, remove this big piece of dead bone, put a big reconstruction plate. Okay, this was where the dead bone was. I was able to restore the mandibular continuity, but now he's left with persistent sleep apnea. After the dome, after the MMA, after all these cleanup operations, he still has sleep apnea and he couldn't drive because he was so symptomatic. And he couldn't tolerate CPAP. So I did a nasal maxillary expansion, improve his nasal airway. He's finally able to use CPAP. He's able to drive. I'm still expanding him. And you can see that gradually, this gradual bone fill from the BMP that I placed. This is before and after I started expanding him. This patient had MMA, 2-3 weeks out, came to see me because his bite is off. And then I saw this granulation tissue, not good. Well, this patient first had dome operation, didn't improve him. Then he had an MMA operation, big chin, yeah. Poorly executed osteotomy. You could see the osteotomy was done very short bone segment, minimal bone contact on both sides, okay? You could see the mandibular displacement, non-union on both sides. Right after surgery, and when he came to see me, non-union on both sides. I had to clean things up, restore him with a large plate. There was a piece of very compromised bone, but I didn't want to remove it because I was really afraid for this guy because he was very likely going to result in bilateral non-union, regardless what I did with the reconstruction plate. Unfortunately, that was what happened. Right now, he's facing a bilateral mandibular reconstruction with hip bone via the external approach. And he still has sleep apnea, and he has chronic facial pain, and he has lower lip spasm from incompetent mentalis muscle, and he's facing a big operation. So, to summarize, as surgeons, we want to select the right patient by looking at what are the favorable prognostic factor for an operation. But at the same, so patient selection. But at the same time, you need to keep in mind what are the things that's going to result in a successful MMA. You do not want to do a 4 or 5 millimeter advancement and then do a 5 millimeter genioplasty and call it as a 10 millimeter advancement. That is not a good operation. And at the same time, you want to make sure that you execute a precise surgical technique. You want to do a good operation. We know what a good operation can be. That's what we need to do to be able to achieve a successful MMA outcome. Thank you very much. I appreciate all your attention.
I'd like to answer the following questions that have been raised by the audience. Number one, concerning both airway and aesthetics, how do you usually decide amount of advancement? Well, I want to emphasize that every jaw surgery case is an airway case, and every jaw surgery case is an aesthetic case, okay? Doesn't matter what the primary driver for the surgery is. You have to always pay attention to the aesthetics and the airway so that at the end of the day, I want happy patients, okay? And there's no sort of standard amount that one should advance because everyone's different. Everyone looks different. I have not used cephalometric for measurements in, I don't know how many years, 20, 25 years since I've been in practice, because it doesn't really matter. What matters is what's going to happen to the soft tissue covering the bone, okay? And it's really more of an art than science, but what I can tell you is that you don't want to do small advancements, as in some of the cases that I've shown, because it's not really going to help the patient a whole lot, okay? So you have to look at the patient, and a lot of times, obviously, I plan it out before the surgery because it's all computerized treatment planning now. And a lot of times, usually I do 2 treatment plans, sometimes 3, depends on the case. I sort of do sort of very relatively conservative, middle of the row, and little or more sort of aggressive in terms of the advancements. I could tell you that I would not consider doing any advancement that's less than 8-9 millimeters. I don't even remember the last time I've done that. Otherwise, I just don't think it's worth it in terms of long-term success with MMA. Now, the population that's I think the most sensitive to aesthetic changes are younger female. Okay, so let's look at some of these cases. This is a sleep case, and you can see that she was a bit mandibular deficient. Now you could see that she had about a 14 millimeter advancement with counterclockwise rotation. And you can see it's a healthy advancement for a young woman. And she had a little baseline sort of gumshoe on one side, which I did not change because otherwise that's going to kick her into a bit of an asymmetry of the mandible. But I think she's aesthetically pleasing after the surgery, and she's much improved. Okay, so again, a youngish female, a bit mandibular deficient. Now that's a pretty decent 14 millimeter advancement. Okay, but I think aesthetically, she was. We could see it next slide. But I just want to point out that in addition to the screws, I added plates. These are not big hunking reconstruction plates. They're placed in addition to the screws to further the stability. I did that because I removed the wisdom teeth at the same time. You can see that she was, in my opinion, has an aesthetically pleasing face, and she's much improved symptomatically. Chinese or Asian women are usually the most difficult in terms of getting the aesthetic correct or enhanced. You can see that the jaw is a bit strong, okay? Some people may not like it, but her main problem was sleep apnea. You could see a relatively significant advancement for her face, which was 13 millimeter at Pagonian. Aesthetically, I think she looked fine. She was happy. She's sleeping much better. She actually sent her husband to me after surgery, and he had an MMA. Okay. I do subspinal in every case, and I do alar cinching in every case. But in Chinese women or Asian women, often the ANS and the muscular attachment to the ANS is very small and weak. So it's harder to limit the widening in Asians, but I think she was acceptable in that it was not a significant widening that led to sort of unaesthetic outcome. From my talk, you saw that maxillary advancement plays a significant role in improving sleep apnea in the MMA. So her mandible needed to be set back a little, otherwise it was just going to be too much. So I set up the mandible back, I think 3 millimeters or 4 millimeters, and then did a little bit of an angulation. So you could see that aesthetically, I think profile looked fine. She was a large, very large, I think that 13 millimeter maxillary advancement, and with lengthening. So you could see that I think that's a good aesthetic result, and her breathing and sleep was much improved. slightly older. You could see that significant midface deficiency. The mandible was way too strong. So this case was managed similarly, very limited setback, but really more of a rotation, but with a large maxillary advancement for her airway. Okay, and some lengthening. I think I think the result is satisfactory. So again, every case is an aesthetic case. Every case is a sleep apnea case. Okay, and it is very important for you to discuss the plan with the patient. And I give them some options and go over my concerns. And at the end of the day, it's a decision between the surgeon and the patient in terms of how much advancement and how the surgery is done. Okay, some surgeons use large strong plates for fixation to maintain large advancement. I would tell you, I used to do that, I think, I don't know, 15, 20 years ago. I don't use big reconstruction plates because at the end of the day, stability of the advancement is determined by, you can influence it by enhancing the bone contact and adaptation. You can use plates and limited screws, and plates and limited plates, and not big reconstruction plates. I'll just show you a case, with a revision case that I did. So you can see that the midline is completely off. The occlusion was open by on the left side, not very good. This patient first had an MMA, not the prettiest case, but the problem, well, you can see that there's a left open bite. Then the surgeon did a second, did a revision because the bite was off. Now the bite is way off, okay? Well, these are big reconstruction plates. A lot of people don't know how to bend reconstruction plates. They're not easy to bend, okay, to adapt. And you could use big plates, but if you don't know how to adapt the plate onto the bone, instead of stabilizing the bone, you're going to pull the bone apart, okay, cause you've seen it, non-union, malunion, infection, etc. It's from people who don't know how to bend plates. This patient came to see me. Now, you're not supposed to see the plates inside the mouth, okay? This patient had a lot of scarring. I did as much as I could, set up the midline and pull as much as I could to try to stabilize the bite. I got pretty close. That could be finished with orthodontics, okay? So big plate does not mean better. So you can see that the there's one more question that I could address, and it is regarding virtual surgical planning, also known as VSP. And can the VSP minimize the complications in those cases that I've talked about? I'll answer it this way. VSP does not do the planning for you. You have to do the planning and you have to design the surgery. That's the first thing. Second thing is that VSP does not do the operation for you. You have to do the operation, okay? So I'm going to review the latest 3 cases, which that I discussed. The 3 most recent cases, I saw them late last year and early this year, okay? One of them was a patient that I discussed earlier. About a 5 millimeter advancement for sleep apnea, and a big genioplasty, 5 or 6 millimeter. And you can see the resulting facial asymmetry, which is fairly significant, okay? Quite asymmetric. On a thin female, that's going to show a lot. And this patient had 2 treatment plans. One was advancement about 6 millimeter. I usually use the right side because left side tends to be a bigger gap. So you use the measurement. So about 6 millimeter advancement in plan 1, 7-ish millimeter advancement on plan 2. Now, plan 1 with the 6-ish millimeter advancement, a custom fabricated plate was done for that plan. Based on that, I would say the probability for the surgeon to do plan 2 or plan B will be very unlikely, right? Because you're going to do a custom plate that's fabricated, that's in your hands already. You don't have to bend the plate. And what's going to make you change your mind to do just 1 more millimeter advancement or less than 1 more millimeter advancement? Not really. So plan A or plan 1 was done. So you can see the resulting facial asymmetry. This was not designed, right? That's the result of the surgery, not the VSP. But the advancement was not good. So the patient continues to have sleep apnea, continues to be symptomatic, yet with facial asymmetry. The VSP didn't, the design wasn't great because the limited advancement, but it didn't design to have a facial asymmetry. Here's another patient that I saw last year where this patient had non-union or mandibular displacement after surgery, bilateral infection, and removal. Had to clean up the mandible. Okay, you could see from this CT scan, the advancement was small. It was a small advancement. Okay, 2 plans were also drawn up for the patient. You can see the initial design was 5.6 versus 7.1 millimeter. Okay, so let's take a look at what was done. Barely much advancement. Okay, and you can actually see the fractures on both sides. So the initial design with the VSP was insufficient for treatment of sleep apnea. And obviously the VSP couldn't have prevented the complication. Here's the other patient that had the bilateral non-union. You can see that there was a very short osteotomy. Okay, on both sides were very short. They were actually at behind the second molar. Now, 2 plans were drawn up for this patient. Plan 1 was a 4 millimeter advancement. Plan 2 was about a 5 millimeter advancement. And you can see the surgical design at the osteotomy done, the vertical osteotomy at the first and second molar. Well, the short osteotomy was not designed by the VSP, right? So, and the patient still has sleep apnea, minimal change with the symptoms. Why? Because the advancement was so limited. Okay. I also like to do 2 plans. Usually one is, decent advancement. The other one, I try to, maximize the advancement. So this case was done last week. And you could see the initial plan was about a 13-ish millimeter advancement at the osteotomy site. A historical point. A lot of the sort of the literature discuss, 10 millimeter at least 10 millimeter advancement. Now, that was in my writing, a lot of my writing, that means at least 10 millimeter, okay? And actually that 10 millimeter came from doing model surgery. So the type of sort of cutting models, mounting models, moving the models to design the splint. Now, 10 millimeter advancement is based on the model cutting. So it is actually at the osteotomy site. If you're doing any sort of rotation, you're going to get more sort of quote unquote advancement if you measure at the B point or especially the pogonion. But really, so what I'm saying is that a 10 millimeter advancement at the osteotomy site is actually less than what is measured based on the pogonion or other sort of measurement points, okay? So this is a 1 week post-op. You can see actually the patient had prior the nasal maxillary expansion. You could see the patient had the subspinal osteotomy. Here's the nasal spine. And you could see it was plan 2, right? The patient was older than the average patient. and he was overweight, is actually a dentist from Virginia. You could see large advancement and some counterclockwise rotation measured at the Pagonia, and it's about 20-ish millimeter advancement. So facial changes, definitely facial changes, but within acceptable range. So why do I keep on harping about extent of advancement? If you look at my data of about 1,000 patients that I discussed earlier, the most recent 500 patients, that's how I do the surgery, right, that I just discussed. Even with that maximum advancement, the surgical success is high, 70, about 80%, okay? And that is short-term success. If you follow the patients out, the success rate is going to gradually deteriorate. So if I'm advancing patients, 13 to 20 some millimeters, and I'm getting about 70 some 80% success rate, imagine what you get by advancing the patient 3, 4, 5, 6 millimeters. So you're going to have a lot of fail. Majority of patients are going to fail. Okay, even if they're lucky, they got some improvement early on, they're going to fail. And what's going to happen? They're going to face basically CPAP, Inspire, which apparently is, all these patients are being offered Inspire, or revision MMA. Okay, so again, take home message. Try not to hurt the patient, maximize the advancement, taking consideration in terms of the facial aesthetics. Thank you very much. I appreciate your invitation to have this lecture with you all.